Welcome. I'm Michelle Cowles, Director of Business Development at Rogers Behavioral Health, and I am your moderator for today's webinar. Joining me today is Dr. Marty Franklin, Clinical Director of Rogers Philadelphia location. Dr. Franklin is a nationally renowned expert in the treatment of OCD, OC spectrum disorders, and body-focused repetitive behaviors, as well as the study and treatment of anxiety and related conditions. Before we get started, I want to give a quick overview of the format. The webinar is scheduled for 90 minutes. There's no need to check in, and to receive your CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available after the program on your personal dashboard, which you may access via an email sent to you by ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next few days to rewatch. Our speaker will give a 75-minute presentation. Following Dr. Franklin's presentation, I will facilitate the Q&A session. If you would like to ask Dr. Franklin a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar, and I will review the questions submitted, and then we will address them during the Q&A portion of the webinar. Now I'll turn it over to Dr. Franklin.
All right. Good afternoon, everybody. Welcome. I'm in this odd position where I'm looking at myself and my slides and not an audience. So I'm going to do my best to make it interactive. I think the reality, though, is because I can't see your responses, I'm going to wait till the end to do questions, if I can do that. Now, I'm going to start off by letting you all know that one of the few upsides of the pandemic has been that I get to spend a lot more time with my 17-year-old son, who's become my Andy Richter to me being Conan O'Brien. So when I was putting this lecture together, he was sitting with me and looking at what I was doing, asked a question about, Tourette Syndrome. I gave him some information about it. And then I said, in an attempt to be hip and cool, which he didn't like that at all, said, I actually can think about this as being my first tic talk. And he looked at me, rolled his eyes, and said, he's a pretty funny kid. He says, for the love of all that is holy, please do not make that dad joke during the lecture. And then I said, well, I have to now. And then he said, well, at least don't involve me in it. I said, Teddy Franklin, I would never consider doing such a thing. So I will let him know that he's been associated with this horrible joke. So TikTok. I'm here to talk about tics. We'll talk a little bit about tics versus Tourette syndrome. It's a distinction that's made in the literature, but it may not be a terribly important one clinically. We're going to talk about treatment using comprehensive behavioral intervention for tics, CBIT. There is tremendous work in the last decade or so that's been done in this area, spearheaded by my dear friend and colleague, Doug Woods, who did a lot of this work when he was at the University of Wisconsin-Milwaukee. He's now the dean of the graduate school at Marquette, so he's back home in Milwaukee after a few years in Texas. And suffice it to say that we are very close collaborators, and there's a lot of the work that I'm presenting today that's really right out of his lab. So I'm going to do my best to do justice to Doug's work and all of his collaborators on the CBIT trials, which I'll be discussing. And just a quick overview, I think this has already been presented. Nothing terribly exciting there. The Q&A feature is what we're going to be using, and I think Michelle's going to be gathering your questions because I'm going to be trying to attend to the lecture itself. And I have nothing to disclose. Very exciting. But I have some things to say, and these are some of the things I'm going to try to get across to you. The core behavioral interventions in CBIT, and the implications of the outcome literature for clinical practice. I think it's really important to know the outcome literature, in large part because we're at a position now where our patients and their families come in And sometimes they know the outcome literature. It's really important for us to have a handle on what has been tested, what is known, what's still yet to be known, and how that plays out. I'm always interested in the research that has direct implications for answering patient questions. I'm going to try to get you to that point where you feel comfortable. If it's not an area of expertise for you, you feel comfortable summarizing the literature for patients if you do decide to treat using CBIT. So we're going to talk about phenomenology of chronic tic disorders and Tourette's, talking a lot of detail about CBIT, and then we're going to look at the outcome literature and see what that tells us and what are its implications for presenting this information for families and then also for clinical practice. And then there'll be moderated Q&A at the end. All right. So phenomenology first, chronic tic disorders and Tourette syndrome. It is a puzzling condition, and there are several things that are puzzling about it. We'll try to put some of these pieces together before we start talking about the intervention itself. So what is a tic? What is Tourette syndrome? Now, Tourette syndrome specifically, it must involve motor and vocal tics simultaneously, meaning the kid or adult has both. Not a history of both, but they're having both in the current phase. So motor tics and also vocal tics. Vocal tics alone would get you a diagnosis of a chronic vocal tic disorder. Motor tics alone would get you a diagnosis of a chronic motor tic disorder. And when you look at whether a person has motor tics or vocal tics or both, which is Tourette syndrome, doesn't seem to be terribly predictable or predictive of outcome or severity or course. So it probably doesn't matter that much clinically, but it is something that we want to be aware of. I know the term Tourette syndrome can sometimes be scary for families. And I try to break that down and basically say it as plainly as I just did, which is all that means is that your kid has both motor and vocal tics, and they all ought to come down with the same axe, which is CBIT. So let's not worry too much about what we call it. The majority of kids, and we know this, more common in males, majority of kids with tics at age 6 won't be adults with tics. The majority are going to age out. We don't really understand that process terribly well. We can't really predict who will and who won't age out. Sometimes those kids with tics at age 6 wind up as kids with OCD. Sometimes they wind up as kids with other kinds of problems. There's certainly a high rate, as you'll see on the right, of ADHD comorbidity. So impulsivity tends to run with tics, which makes a lot of sense. It's an impulsive outburst, if you will, of behavior. In terms of comorbidity, anxiety disorder comorbidity is common, OCD in particular. You do see some panic disorder, specific phobias. You see that all over the map anyway, but maybe a higher base rate of fears than you might see in a population without tics or Tourette syndrome. Major depression is not uncommon. Maybe downstream effect of functional impairment, maybe not. ADHD, like I said, the vast majority are going to have ADHD and or learning disability. It's going to take you a little time to figure out clinically whether we're talking about legitimate ADHD or distraction by the tic process. And that's worth parse as you go. So both tics and Tourette syndrome and chronic motor tics, no one's arguing that this is not a biologic process. At this point, it's got neurobiological origins in the basal ganglia. Interestingly enough, it's the same area that's implicated in Parkinson's disease. So there's a movement center, if you will. And then the movement center, there's some kind of issue, glitch in that movement center that leads people to do a lot of movements that they hadn't necessarily thought of as being functional movements. There's a genetic contribution, higher rates of Tourette's in the family tree for somebody who has Tourette's, but it's not like eye color. It's increased, but it's not a guarantee. So if you have tics, doesn't necessarily mean your kids will have tics, but they're at a higher rate of vulnerability to that. There's certainly environmental influences, which we'll talk about, attention and some internal environment, if you will, which is what happens when I do my tick, what happens to the unpleasant premonitory urge that I don't like. We'll talk about that. That's fundamental to the model of how this works, and then it's fundamental to the treatment. A question I ask all the time is, if it's biological, can we change it? And the answer is, of course. All of these things are biological, some more than others. But just because the factors associated with etiology may or may not be the factors associated with maintenance. And so the things that are maintaining tick behavior are things that we can get our hands on. And I think that leaves us open for hopefulness. And are biological treatments necessary? And the answer is probably not. I would say that there are certain the comorbidities. If I've got a depressed kid or an anxious kid who also has tics, then I may want to go after the anxiety and depression with a medicine of established efficacy for that. And I think that there are places where certainly we've seen, and I'll show you the CBIT data and talk about that a bit from their big trials, that there are people who go in and they do the behavioral intervention, they do fine, even though they're not even on a medicine. So it's not necessary to get change, but sometimes to manage the comorbidities, it does seem to be helpful. And there are some medicines used directly for tics, which we'll also talk about. I think diabetes is a pretty good analogy for these conditions, including Tourette's and chronic tics, which is, no one's arguing with somebody who has diabetes that their pancreas is not working the way it should. However, there are behaviors you can engage in and not engage in, such as exercise and eating right, that will influence the course of illness. It doesn't necessarily wipe away the problem with the pancreas, but it certainly provides you ways for the downstream effects of that condition to be realized less than it would be if you let those things float. And obviously, in the case of diabetes, you're also talking about probably the necessity of insulin. Here, I think it's a little more of an open question. Okay, so tics, they can be simple or they can be complex. The most common simple tic, I don't know if you can pick this up as I'm doing this, I'm a little bit in the shadows, is a hard eye blink, or a blink like this. Hamsters do this one. They blink one at a time only. But you see that sometimes as being a really common early onset tic. Some eye movements or hard blinking. You can also have a jerk of a shoulder like this as a simple tic. Sometimes it's part of a more complex pattern. So if I have to do my eye thing, then I have to roll my neck, then I have to move my shoulder. That whole sequence is part of a complex tic. But simple tics are more common than complex tics. Tics wax and wane. You may have tics for a couple months and the particular tic you had dissipates and then a new one pops up. They tend to be occurring in bouts. So you might go quiescent for a little bit, then you start doing your tic, and next thing you know, you're engaged in a process where it continues on at a fairly high rate. And if you're responding to the tic urge by doing the tic, you're probably reinforcing this whole process. And then it may go quiescent again for reasons that we don't fully understand. But in behavior therapy, we're trying to influence that process, getting people to be more aware of when they're ticking, of when they're going to tic, and trying to do something about that, which we'll talk about in the context of discussing what we call competing responses or habit reversal training. The topography of tics changes. They tend to start from the head down. And you've got people sometimes who have neck tics who then move into foot tics and things like that. But more commonly, you're going to see them starting at the head and face. Facial movements, this sort of thing. I don't know if you can pick that up on what I'm doing. But there's a few of those. And like the surprise face is a pretty common one. So widening my eyes in response to an urge to widen my eyes as opposed to hearing something shocking. So developmentally, we do see a pattern. Tend to be simpler tics and greater preponderance of simpler tics in the beginning, followed by the development of complex tics and other body tics as kids get older, those who maintain their tics. and usually preceded by a premonitory urge. If you're 6, you're not very aware of what's happening before your tic. That's one thing we have seen. Around age 8 or 9, though, kids can report pretty reliably on there's a feeling. So I get a feeling in my shoulder before I have to raise it. And it's like muscle tension. They talk about it as muscle tension, and it builds and builds and builds. And if I raise my shoulder, sometimes it's until it feels right. For other kids, it's a certain number of times. I have to do it 4 times, which raises interesting diagnostic questions for OCD. Long and short of it is, if it's coming from a physical symptom as opposed to a thought, a cognition, we tend to put it into the tic Tourette's pattern. And those urges are very important in terms of what we wind up doing with that in behavior therapy. So this is flying through a little faster than I would have liked. Huh. Way faster. All right, let me go back. See if I can unpack this. There we go. So, oh, it jumped ahead on me again. Well, I'll leave the prior slide. Looks like this one will stay in place. So the negative reinforcement hypothesis of tic maintenance is really important. So what maintains tics? And if indeed there's a premonitory urge, a physical feeling, more like an itch. People talk about it a lot like an itch. I mean, those of us who have itches from time to time, we know it's hard not to scratch them. And you have the urge coming first, then the person engages in the tic behavior, whatever the case may be. When they engage in that tic behavior, oftentimes there's at least some relief of the urge. Sometimes complete relief, but more commonly it's some relief. And that some relief is what we call negative reinforcement, the removal of an unpleasant stimulus or sensation, which sounds like a good thing. So I took care of it, right? But the problem is that that's a maintaining variable. So now I had an urge to do my shoulder tic. I did it. I get temporary relief, but now, next time that urge emerges, which might be right away, might be a little bit further down the line, I have a recognition, I don't know how conscious this is for little guys, but I have a recognition that I have my urge back and I better do this to get rid of it again. So then you wind up reinforcing the process. I think the biology of those tic urges is not terribly well understood. We certainly have evidence that it's emanating from the basal ganglia and working its way up into the cortex, which is then what happens is movement, cognition and movement follow. But we want to be aware of that so that we can influence it down the road in behavior therapy. That's what we're going to be about. You'll see it in a minute. So, psychologists are interested in the environment-tic relationships. So there are events in the world that push and pull tics around. And sometimes it's attention, sometimes it's stress, sometimes it's people's responses to your tics. With everything, there's always going to be an antecedent and a consequence. Some of those antecedents and consequences can be internal. So the urge, I think that's a good example. The antecedent to the tic is the feeling. Then I do the behavior. The consequence of the behavior is the reduction of urge. And then that sets the stage for maintaining tics. But again, those things can be external. So if I start doing my movements and the teacher tells me I need to stop doing my movements, that's distracting to the other students, it could be that the external response to my ticking draws more attention to it, might heighten the sensation that I'm having, and now I'm going to do more movements. Next thing you know, I'm going to be asked to leave math class. And again, I don't think any of these kids are necessarily looking to leave math class, but when they leave math class, some of the other variables, the internal and external antecedents, change. So now I'm in the hallway alone. I'm not under the stress of having to figure out some geometry. And then it might be that the urges go down, which then that essentially by leaving the situation, I just reinforced the whole process. And understanding how that environment impacts tics, we can modify the environment, which again, I'll talk about when we get to the details of CBIT. So basically, these are, and it's interesting, is it's very individualized. There's no one size fits all here. So tics can be made more frequent in some people by social reaction, by parental attention, positive or negative, or parental comforting, peer attention, escape from the aversive situation. I don't want to trash geometry, but some people want to leave geometry class. And it feels good to leave geometry class, even if you weren't planning on it. And the reduction, maybe the most potent of all of these consequences, the reduction of the premonitory urge as a result of doing the tic reinforces doing the tic. But we also know that tics can be made less frequent by reinforcing tic suppression. And a lot of interesting work done in Doug's lab in the early 2000s about essentially paying kids to not do their tics. And what's interesting is for a brief period of time, you can get kids to do really well if you're going to pay them right away, little coins that they can exchange for presents and prizes. You can get, even little kids can get pretty good at not doing their tics because they're getting reinforced for not doing tics. Potential reinforcers for suppression also can include, I don't want to get teased, being able to participate in a social activity or sport. I coach baseball and softball, and I've had a number of kids who have tics. And what's fascinating to me is to watch them in the batter's box. So when somebody's throwing a ball at you very hard, it's probably pretty important to maintain your concentration and not be moving a lot when the ball's coming. And there was a fellow who played for the Philadelphia Phillies and I think the Minnesota Twins and the Kansas City Royals by the name of Jim Eisenreich, who had Tourette Syndrome. And what's interesting about Eisenreich is when he was in the outfield, he was center fielder and a right fielder. When he was in the outfield, he was engaging in a lot of tic behavior. But when he stepped into the batter's box, it went completely silent. And I don't think he was being treated for it. It was more like his concentration on a ball being thrown at him 95 miles an hour overrode his focus on the tic urges. And then he didn't do any tics in the batter's box. Outside the batter's box, yes. In the field, yes. In the batter's box, nothing. And that's not always the case. That was the case for Eisenreich. And we want to pay attention to that because for kids, who are interested in sports and they think their tics are getting in the way, it could lead them to not play, it could lead them to step out of an at bat or to cut off some positively reinforcing element of their lives out of fear of embarrassment, and then you wind up with the world getting smaller. So we want to teach kids how to use the competing response training we're talking about in CBIT, so they can maintain their social and intellectual and athletic and music development as well. It's part of the trick, if you will. So I'm putting this slide back up here because I think it's interesting, which is this is the same slide I use in my OCD lectures, which is obsessions give rise to anxiety or distress, and compulsions reduce it. So we have negative reinforcement. It's the same process. The only difference is whether it's a premonitory urge, which is more of a physical sensation or stimulus, as opposed to a mental one. With OCD, it's more commonly going to be a thought like, oh, I just touched something. How do I know it's not contaminated? Or how do I know for sure I locked my car? I just came up here and maybe I didn't lock my car. Maybe now I have an urge to go check my car. And then if I go check my car, customarily, I'm going to find my car is locked. That's going to provide negative reinforcement. So some relief from having checked, but then the next time that happens, maybe even right when I come back again, I'm going to say, well, how do I know for sure that it was locked? How do I know? Maybe I got confused. I ought to go back. And you wind up going back and reinforcing this process. So you see the overlap in these two cycles, and I think that's an interesting place to think for me about what's different between Tourette syndrome and OCD. And to me, when I'm thinking about it, we used to say that one was voluntary and one wasn't. But I think we understand tics a lot better in the last 20 years to know that there's an intentional function to ticking, which is to eliminate or reduce the premonitory urge. So I think that distinction between intentional, unintentional is not so useful anymore. I think a better distinction is whether the prompt is cognitive or whether it's more of a physical feeling. And obviously you have people who have a bit of both going on. We'll talk about them as we go as well. So treatment for OCD essentially comes down to that. I want you to have your obsessions. I want you to be uncomfortable. I want you to stop engaging in your compulsions and shut off the valve of negative reinforcement. So back to the person with the car, for example. That person, I would want them to lock their car once, come up to the office or take a walk around the block, and not go back until they have to go back to get the car, even though they have urges to go back. I want them to learn how to tolerate that discomfort, challenge those cognitions, and then eventually when they go back to the car and it's still there, which is usually the case, even here in Philadelphia, when you go back and your car is still there, it provides what Foe and Kozak used to call corrective information. So if I have an urge to wash my hands and I touch something and now I want to wash them, if I tolerate the discomfort and don't give in to the compulsion, eventually the frequency and intensity of those obsessions and the associated anxiety is going to come down. It's going to get easier not to wash over time. And with a lot of repetition, I'm going to see the frequency, intensity drop, job gets easier, and then I'm freer of this cycle. That's the idea in the treatment. So you can see if that's the treatment for OCD, you can kind of see where I'm going with CBIT. And because of this overlap phenomenologically, there's a good question, which is why wasn't Tourette's moved in DSM-5 to be put under OCD and related conditions? And this is a quote from Sir Alec Izagonis, who was a car maker in Britain. And he was not a big fan of sitting down at the conference table and getting other people's ideas. He wanted to make the cars. The Mini, I think, was his claim to fame. He wanted to make his cars the way he wanted to make them. And when once forced into a committee, he was suggestive of that maybe committees are not always a good thing. So a camel is a horse designed by a committee. And the reason I raise this is because DSM-5 is a process. It's a committee process. And even though there's a good argument to be made that these things are so similar, they should be in the same category, there are historic reasons why the folks who were advocates of and researchers in Tourette syndrome did not want to see this condition subsumed by OCD. And in part because I think they took a long time getting acceptance in the medical community and getting validity associated with this being a medical process as opposed to some other process. I mean, and you know, back in the day, this was the kind of thing that led people to be accused of being possessed, Tourette. So they were very sensitive to having this subsumed in some other way, and they felt like they might be giving up some of their medical street cred, if you will, by having it subsumed, and then the committees relented, as committees will do at times. And if you're interested in a deep dive in that whole process, this is one of the most influential books I've ever read. Thomas Kuhn is a philosopher of science at Princeton University for a long time, wrote The Structure of Scientific Revolutions, and was really using examples from physics and chemistry and hard sciences, and essentially introducing the idea that it's a human endeavor, science, and it's influenced by the subjective. It's influenced by paradigm shifting, which is where that concept came from. And I'm sure Kuhn had his own influences before that, but the long and the short of it is there are sometimes reasons that have to do with science as to why things get shifted and not shifted, and sometimes they have to do with human endeavor. So important to keep in mind. Great book. It was a page turner. I remember when it was assigned to me as a graduate student at Villanova University, I did not assume this would be a page turner. It was. Well worth the trouble. So let's talk about CBIT. So now we've talked phenomenology, and phenomenology oftentimes, and maybe when phenomenology isn't influencing your treatment, you ought to ask yourself some hard questions. But when phenomenology is directly influencing your treatment intervention, then that seems to make a lot more sense. At least it's face valid. So CBIT, Comprehensive Behavioral Interventions for Tics. Those of us who've been in the field for a while recognize this as the guts of it is what we call habit reversal training. That was something that was created in the early 1970s. Nate Azarin was a seminal person in moving that treatment for use with what he called habits. And those habits came to include over time tics and trichotillomania, skin picking, nail biting, etc. So if you recognize in here a lot of HRT, that's not surprising. There's other pieces to CBIT, which I think I gave you a preview of coming attractions. CBIT essentially comes down to three main procedures. And the first is awareness training. The second is the guts of what we call competing response training or habit reversal training. And social support is the third leg of that three-legged stool for CBIT. So let's talk about these legs as we go. So again, it's a puzzle. And how do we puzzle our way through it? I want to know the phenomenology of the person in front of me. I understand there are some common threads in everybody who's got tics, but then the individual level data, the tree as opposed to the forest, I need to get a really good understanding of how the tics work in the particular person who's in front of me in order to be able to create the interventions and then do trial and error and see how well things are working. So it's a puzzle. It's always a puzzle. Just because you diagnose it doesn't mean that CBIT will readily flow from simply having a diagnosis. It won't. So awareness training. Can't fight what you can't see. And what you're trying to do is you're going to try to help the client discriminate episodes of behavior. It's a fancy way of letting them know we're trying to find out when this is happening. And it's sometimes these things are really important. I'll give you an example from my coaching career. My own middle daughter, who graduated from Pitt last week, but when she just made the varsity softball team as a freshman, which shocked absolutely no one except her. But she gets a starting job, and her big sister was the captain of that team. And so we're in the batting cage on a weekend, and I'm working with her on my middle kid on a hand placement. And you know, when you're facing pitchers who aren't that fast, your hand placement's not as important as it will become when you're facing varsity level pitching. And so her hands were way up here, like a baseball player, wagging the bat up here. And what's interesting is baseball, you've got another 20 feet to get the bat down. If your hands are up here and the pitcher's 40 feet away, you have no time to bring him down. And I'm standing there watching her in the batting cage with her hands way up here. And my older daughter, who was a varsity star, turns to me under her breath, she protected her sister's feelings and said, "You have to do something about that. Her hands are too high. She's not going to have time. She's going to be late on everything." So what we did before the season started, we did these exercises, which I would think of as being awareness training, that she wasn't aware of how high her hands were. And so we did these practices where I had her simply hold a bat, an invisible bat. Hold a bat, and when I say go, you just bring your hands up to here. Not here, too high. Bring them up to here. Bring your hands back. Good. And then all I did was reinforce her doing that. Good job. We would do this for an hour a night. All me standing there saying, "Good job, too high, good job, to get her in the position where her hands weren't so high so she could get the bat around when she's facing faster pitching. And her first varsity at bat, she ripped a 2-run single to center field off a pretty fast pitcher. And what's interesting is if I handed her a broom right now or a bat, this is 8 years out, her hands would go right to here. There's a lot of repetition, a lot of improving her awareness, and then doing the muscle memory that you need to do. So when it comes to tics, what does that do with tics? I need you to know when this happens. I need you to know the entire sequence of your tic. Better yet, I need you to know when it's coming. So we do these 3 techniques in awareness training in the first couple of sessions of HRT or CBIT. Response description. So tell me, like, I tell people, I want you to explain this tic to me in the same way that if you were writing a script. There was a movie came out years ago, really good movie called Prisoners. And Jake Gyllenhaal plays a detective who has Tourette's. And it's not a big part of the story, but you see, it's almost like it's an indicator of the stress the character's under when he starts ticking more. Motor tics mainly, but there are some vocalizations in there. I've never seen anybody do that as well as Gyllenhaal did. And what's interesting is that's what I'm looking for. I want you to describe your tic in such detail that I could do it myself. Tell me where it starts. Tell me what the first movement is. Tell me what the next movement is, because I want you to be able to be conscious of it, because then we may be able to catch it sooner. So the early warning, and that really comes down to the recognizing the urge. But if you don't get the urge, like if you're little and you're not attentive to that, you might be able to catch the first sign of the tic. So it's best if I feel it already in my shoulder. That's going to allow me to intervene sooner. But if I just don't get a feeling or I don't notice the feeling and I start doing the tic, then the presence of the tic becomes the early warning sign. And then I can build on that to build out the habit reversal. And response detection is a little game you play. So I do their tic and they're supposed to catch me doing their tic. So we're having a regular conversation. Every time that I do their tic, they put their hand up, they put their hand up. And if they miss one, I let them know. And then I catch their tics and we go back and forth reversing to get them even better at recognition. So recognition is important. And I think that my daughter Delia would probably tell you that she now is consciously aware of where her hands are in space. And she also is very, very conscious of the implications of that for her. If her hands are too high, she's not getting around. Same thing here. So the steps of this, I'm really trying to get in awareness training again. First session or second session, maybe both. Give the rationale. I tell them all the time, you can't fight what you can't see. If you don't know what's coming, it's going to be much harder to know what to do. And then the tic and the warning signs. So what is your tic? What are the physical features that you notice when you're about to do your tic? And then I'm having them acknowledge my tics. I'm acknowledging them doing their own tics. Then I'm having them catch their own tics. That's the next step in awareness training is you tell me. Every time you do your tic, let me know. Every time you have an urge to do your tic, you let me know. So getting them to be more aware. So now we get into competing response training, habit reversal. And you know, it comes from that language, back from Asrin, about habit disorders. And so I'm reversing a habit essentially. And it's kind of interesting to think about because we really are trying to do that. We're trying to replace the target, the tic, whatever the case may be. In our case, it's going to be a tic. I'm trying to replace the tic with a physically incompatible behavior. So when you have an urge to do your shoulder thing, bring that shoulder up 3-4 times. I want you to do this instead. I want you to sit flat. I want you to take your upper arm and push it against your body. In part because it's incompatible with, I can't be bringing my shoulder up and having my body, my arm push against my body at the same time. So that's how they're physically incompatible. We want to get them to do it best yet when they get the warning sign. When you get the urge in your shoulder, I want you to start pressing your arms against your body. And I have some kids who only tic on the right, in which case what the left arm does doesn't make any difference. But oftentimes it's both. So pushing your arms against your body, not so hard that you're going to pass out, but hard enough to provide some tension, muscle tension. And I want them to do that at the sign of the urge or if they noticed the tic already. So if somebody missed it, okay, now I just did 3 tics. Now I got to bring them down and push them in. Push again, not super hard, but hard enough for it to be noticeable. Okay? Oh, there we go. Lost my cursor. There we go. So what's interesting is when we first started fooling around with this in the early 70s and in the 80s, competing response training, the idea was that the competing response had to be physically incompatible with doing the tic in order to be effective. So if I had a vocal tic, so it's like a screaming tic or something like that, I'm going to see if I can do one of those for you. This is a lot better in person, but we'll have to settle. So I'll set up a little silence. My vocal tic is coming. Ah! Y'all hear that okay? Pretty loud. My coaching voice can carry. So I might have that as my tic. Customarily, when we're doing competing response training back in the day, the competing response for a vocal tic of pretty much any kind is going to be a breathing exercise. And it's a breath in through the mouth, and not like you're swimming, like just a small breath between with the mouth open. And you hold it, and then you breathe out slowly through your nose. Now, it's physically incompatible because I can't be breathing out slowly through my nose and doing ah! at the same time. So you see how that would work. So at one point, when Azrin and Nunn and other folks, Alan Peterson was central in this work as well. When they first started working with Tourette syndrome, they were thinking that the competing response had to be physically incompatible. And it does make intuitive sense. I have a neck tic. I'm going to want to have a physically incompatible competing response that works that way. But there's lots of interesting work done in Doug's lab, and this is the place where a lot of this important stuff happened, that suggests that it doesn't have to be. So if I randomly assign kids to either get a physically incompatible competing response versus one that does nothing to do with your tic. So I have a vocal tic. I've got people pushing their feet. You can't see my feet, but I got my pushing my feet into the floor as if I'm about to get up from a seated position. That would be my competing response for vocal tic if I'm randomized to the second condition. And the answer was, didn't make a difference. So it raised lots of interesting questions about, well, if it's not muscle tension, what the heck is going on? How does this work? And it may well be that I'm reallocating attention away from the physical feeling, away from that premonitory urge, and towards some other thing. So if I've got to get my feet together and I'm concentrating on pushing my feet, maybe I'm not noticing as much about that feeling in my shoulder. So there's some flexibility to this. Even now, though, I still tend to start with a competing response that is physically incompatible. Even now, and you know, there's some studies yet to be done, larger studies that would maybe say if that's good or not. But I certainly have worked with people where the competing response being physically incompatible doesn't work as well. So I got the flexibility to do what I need. And the competing response is supposed to be held for a minute, not for 3, because that's too long to get good compliance, and not for 30 seconds or shorter, because it's not long enough for the urge to dissipate. It's about a minute. And you got to teach little guys how long a minute is. Little guys often don't know how long a minute is. You got to sit there with a big clock and show them. And you're going to hold that for a minute or until the urge goes away. And then you sort of, what I say is you hold your competing response for a minute. And after a minute, you look at the clock. Okay, it's 1:45. And I sort of take the temperature of the urge. If the urge temperature is still really high and I want to go right back to ticking, I go back into my competing response. What's interesting is you can fade the competing responses as the tics fade. So if I'm not reinforcing tics, theoretically then, I ought to see a reduction in the urge strength. And as the urge strength gets weaker, you can just not do your tics. Lots of interesting work that's been done there too. The long and short of it is in the beginning, when I'm teaching this, I'm going to really want to be disciplined about getting them to do their competing responses in the situations that matter to them. And the third leg on the stool, social support. Reinforcing and prompting urges of, prompting use of competing responses. A lot of times this falls on the parent. If we're talking about treating kids, it's teaching the parents to do this stuff well. And sometimes you got to see where they're starting from. If you're starting with a family where there's a lot of back and forth and a lot of negative interaction around tics, you're going to need to spend some time clinically getting that to be not the case, because it's unpleasant in and of itself. It's compromising these relationships that are really important, because it's hard to get yelled at for doing your tics. But you're also going to need to get them to do something else. So the significant, and it could be a spouse, we're talking about an adult, or even a friend that you spend a lot of time with, and getting them to prompt the use of the competing response. And to do so in a way that's gentle and kind, right? Oh my God, use your techniques, would you? Is not what we're shooting for. That might be where you're starting, but you gotta, you know, and sometimes it can even just be a pat on the arm. That was my dad's signature move. He would just pat you on the forearm if he wanted you to calm down in some way. And so he would just, so a pat on the arm, a pat on the shoulder might be, you know, an agreed upon in advance move that the kid is sanctioned, where the parent is just saying, you know, let's get the techniques going. And if they are using the techniques, so you know the kid is using their competing responses, you praise and reinforce that. There's not great data on how much of that is essential. We certainly know there are kids who don't get much of that at home and they still seem to do well with CBIT. And there are kids for whom they get all of that and they're still struggling with tics. So it's not, the causality there and the degree to which it's necessary is unclear. But certainly the younger the kid, the more I'm going to need to involve the parent in creating what we call a tic neutral environment at the very least, but also using the knowledge to reinforce the use of the techniques that we're teaching. I got ahead of myself. The tic neutral environment. So identifying who's going to help do that, training them in reminders in an encouraging tone, not a punitive tone, praising the praising of the client. So if somebody's practicing this in my office and I see the parent doing a good job with that, I'm gonna be telling them, good job. Just right back to the, you know, every time my daughter put her hands in the right spot, good job, good job, good job. I mean, I must have said it like 50,000 times over the course of her softball career, and it seemed to work. And at some point, I didn't have to do it anymore. I faded out because she knew it was just, that's naturally where her hands go now. Okay. So we also have ancillary school-based interventions depending on the degree to which the tics are disruptive in school. And I may even consider doing psychoed in the classroom if this is a problem. And letting people know, letting the administration know, letting the school psychologists know what we're doing and why, and how to get them on board to use the same methods we're using at home. So a signal for the use of the competing response, a signal for effort, and again, creation of that tic neutral environment. The kid tics, they tick. You don't need to yell at them. You don't need to make a big deal out of it. You don't need to rescue them either. Just let them go about their business. And if there's anybody teasing, then we need to come down pretty hard on that. I'm not a big fan of teasing. And I am a big fan of trying to address that right there in the moment if I can. So you also may add relaxation training if you got a kid who's very tense or is having a lot of physical symptoms as a result of doing tics all day. You may teach them some relaxation training, not in response to the tic as much as it is sort of to lower the, as they say, the lowering tide lowers all boats. If I can teach you some methods to calm yourself down at night, that may have some downstream positive effects. Function-based interventions. So a good example from one of Doug's books is a kid comes home after school and they've been suppressing their tics, and then they come home and they're in a safe environment. They come home and they're ticking a lot, and they wind up getting into an argument with their older sister about all the noise. And if the parent then, tells the sister to go to her room and gives the kid the TV room and strokes his hair and gets him a snack, you've just reinforced ticking. So we want to pay some attention to those kinds of, what's the function of this? How's this working? And pay some attention to that. Token economy, as I said, paying kids to not do their tics. Or I guess better way to put it is really pay them for using their techniques and participating actively in treatment. We often will set up those kinds of reward systems for coming into session, for bringing their materials to session, for engaging in the practices, for completing the homeworks. So I'm not like I'm not punishing them for having tics. It's more like I'm rewarding and reinforcing them for trying to use the techniques. And self-monitoring, the older the kid, the easier it is going to be. But as a way to assess progress, sometimes I'll have parents involved in that. I'll give them a 10-minute homework assignment to count how many tics you see in a 3-minute period when they're not using the competing responses versus when they are, and reward and reinforce those very ABA kind of techniques, reversals we call them. Okay, so development plays a role in all of this, as you'd imagine. And I think there are some pieces that I think are here. Awareness of tic phenomenology, the younger the kid, the less you're going to get that. So you may be using the competing response. The prompt to use the competing response might be the tic itself for the little guys. Around age 9 is when you expect them to be more aware. But there's a plus or minus to that. I've got some 15-year-olds who are not aware. I've got some 7-year-olds who can tell you exactly when the urge is coming. You want to work on where they are. Readiness for behavior change. Is this a priority for the kid? And if it is a priority, then we want to build upon it. If it's not a priority and the kids say, I don't care about this eye blinking thing, everybody else seems to, it doesn't bother me. Then I've got to ask myself, why am I working on eye blinking if it doesn't bother the kid? And I may want to improve their awareness of it being in the way, but if it's not in the way, it's not a priority for the kid. I got to ask myself, is this the right time and the right place for CBIT? And the family response to the tics is also a major place for intervention. And the younger the person, the more embedded in their family they're going to be. I want to pay attention to that. Okay, let's talk treatment outcome. I'm going to give you a forest level look at the literature and what it may mean for you going forward. A few things I think we can discern from this lit. But what does it tell us? First thing I would say is we've got a number of things that have been tried. And on the med side, I would say we don't have perfect treatments by any stretch. The oral alpha agonists like guanfacine have been used. Atypical neuroleptics like risperidone have been used to some efficacy relative to placebo. The problem, of course, is you've got to balance the response with the side effect profile. And with things like risperidone, it's really important to do that. And I leave that to the psychiatrist to sort. But what I would say is I don't have a clear winner. I don't have you must put the kid on this medicine based on the lit. The behavioral treatments, including HRT, have been studied. We'll talk about that in more detail. We don't have any evidence for physical or dietary interventions. Doesn't mean that there's not something to be found there, but it just hasn't been discovered and it hasn't been tested in the way that we are comfortable. And having a few anecdotes here and there. John March uses a line which I really like, which is the plural of anecdote is not data. So I want to be careful to endorse a particular form of intervention if I don't have strong evidence. I want to be able to think clearly about this, so I don't wind up wasting people's times on unnecessary or irrelevant interventions. And then what we don't have, this is a huge gap in this lit still. We don't, in OCD, we have a bunch of these studies. In tics and Tourette's, we don't, which is a direct comparison of the relative versus combined treatment efficacy for meds versus HRT CBIT. That seems like a gap you can drive a truck through, but it hasn't been done. So it leaves us in this position where I can't say in a given sample that meds are not as effective or are as effective as CBT or CBIT, or that combined treatment is necessarily better. I don't have that in the same sample. And the problem with comparing across samples is you don't know how those samples are similar or different. So it leads you to be a little more circumspect in how you're going to describe that lit. We don't have a definitive med. We don't have a med that's universally effective. We don't have a CBT that's universally effective, but I'll walk you through the CBT lit a little bit more in detail now. But there are some holes. And this is Craig Whittington, really nice summary. If you want to know this lit pretty well, it's nice to get a good summary article or review article. It was an outstanding one, and one of the ones I've relied on to help guide my own thinking as to what's out there. And this is a pretty recent article too. So what do we know about the HRT competing response training? CBIT. This is back in the day with transient and chronic tics not well defined. Asrin and Nunn, 1973, kind of a seminal paper. It was effective. The HRT procedure, which is basically do behavior B in response to your urge instead of behavior A, which is exactly what we're still doing. And we've added some techniques to that, but that's essentially what it is. And it seems to be effective in reducing or eliminating motor tics in adults and children. They had a lot of kids who reported no more tics. I don't think their follow-up was great. So there's some unanswered questions there. But as an initial step, it was very encouraging. When they applied it more formally and diagnostically in a formal manner, requiring Tourette Syndrome, which is motor and vocal tics simultaneously, Alan Peterson, again, one of the key figures in this field, found that HRT was more effective than either relaxation training itself or self-monitoring alone, which is good. It was more effective than wait list, which is, you better beat wait list if you're going to be a serious treatment, and they did. And then when they looked at it, it was a higher bar. This was in adults. Sabina Wilhelm did this a couple of times. More effective than supportive psychotherapy. And then the seminal trial, that one of those was 2012 paper, was one of the CBIT adult trial. And the CBIT kid trial, which I'll be talking about in more detail, Passantini and colleagues found that CBIT as a package was more effective than supportive psychotherapy. And supportive psychotherapy is a pretty high bar. If you're teaching kids and families about Tourette's, and you're teaching them about the effects of Tourette's, and you're providing support and ongoing assistance in that way, but you're not doing any specific interventions about the tics themselves. So as a comparison group, it's a pretty good one. There's an active element to that. And you'll see the CBIT trial, the kid data, clear differences there that are maintained over follow-up. And these are the ones I'm talking about. These are the key trials done in over the course of the early 2000s. I think the first paper, Passantini, came out in 2010. Was the kid trial. And in 2012 was the Wilhelm multi-site. And again, these are big multi-site studies. A lot of the studies that preceded these are, ends are like 15 if you're lucky. They had 120 kids and adults in separate studies. Everybody had a diagnosis of either Tourette's or a chronic tic disorder. So if you had just had motor or you just had vocal and you met diagnostic criteria for chronic, you were allowed to be in. And Tourette per se wasn't predictive of outcome, which is why we tend to gloss it a little bit. CBIT was delivered in 8 sessions over 10 weeks. There was a comprehensive multimodal assessment at baseline, at midpoint, 5 weeks and 10 weeks. And then they had both 3 and 6 month follow-up phases when the treatments were stopped. And they just invited you back to come and look at your symptoms again. The participating sites for the kid recruitment, Passantini at UCLA, John Walkup at Hopkins, and University of Wisconsin, he's now at University of Chicago. University of Wisconsin, Milwaukee with Doug Woods. Doug's now at Marquette. And then the adult study they did, MGH Harvard was one of the recruiting sites. The Yale Child Study Center, oddly enough, was one of the adult trials. And University of Texas Health Sciences Center under the auspices of Alan Peterson. These were funded through big R01s, actually given to the Tourette Syndrome Association, now the Tourette Association of America. And the collaborative R01 mechanism was used. These are big grants, big trials, and by far the most important interventions, trials that have ever been done in Tourette's or tics. So what's in CBIT? I think we talked a little bit about this. I'll talk about it in more detail as far as formally what was in it. Psychoeducation, habit reversal, just as I described, teaching people to do behavior B instead of behavior A. Function-based interventions, trying to figure out how the tics are being pushed and pulled in the environment and modifying the environment in response to what you're seeing. Reward systems and relaxation training where needed. Again, not in response to the tics, just to try to lower the temperature, if you will, and reduce some of that muscle tension that people often report where they're doing a lot of motor tics. The comparison conditions, psychoed, supportive counseling. They talked about tic phenomenology and prevalence and the history of tics, what common comorbidities you might expect to see, putative causes, psychosocial impairment, but they also provided a lot of non-specific support. And it was matched to CBIT in terms of time, so how much time was spent in the intervention each week, and number of sessions. So it was meant to be a control for those non-specific effects, and also the passage time. Okay. And this is the primary outcome from the CBIT trial, Passantini, 2010. We had, when you look at CGI, which a lot of times in psychiatry trials, that's your primary outcome measure. More kids in the treatment group, I think it was about 57% versus 20 some odd percent in supportive counseling, were rated as improved, very much improved. This is the Yale Global Tic Severity Scale. And basically what you're seeing here is in HRT, you're seeing a decent reduction, almost a 10-point reduction, and right to the edge of clinically significant tics on the Yale. 15 or so is usually what you're shooting for. And they ended up at post-treatment right around there. And a little bit of a reduction. Supportive counseling wasn't entirely inert, but it wasn't as effective. This is from baseline to post. When you look at follow-up, though, is where you see these things even extending further. So 89% of the kids who responded to CBIT were still maintaining their gains at 6-month follow-up. Very encouraging. As opposed to, there was more evidence for relapse in the supportive counseling group. So very encouraging. And on the heels of that, really almost simultaneously, we were actually at my lab at Penn, back when I was there, we were looking at, can we augment HRT or CBIT, if you will? Can we augment that using the techniques of ACT, acceptance and commitment therapy from Steve Hayes? Because we've seen some positive effects with other disorders, OCD, trichotillomania, et cetera, using ACT. Or ACT, acceptance enhanced behavior therapy, as is alluded to. We had 7 kids come through, 4 of whom were treated at Duke, 3 at Penn on the initial phase of this. And we're basically trying to see, can we do HRT? Can we do CBIT and not mess it up? And then what we did after we treated those 7 kids, we added 6 more kids to see how do we do, when we add elements of ACT, how do we do relative to how we did initially? And the answer was, we didn't see any enhancements with ACT in our trial, and probably it was because we were doing a really good job with CBIT. Our post-treatment CBIT scores on the Yale were about a 12. And if you remember what I said about 15 being the cut for clinical significance, and 12 is below that. It was hard to do better than what we were doing with kids who have chronic motor tics or Tourette syndrome. And so there wasn't a lot of room to be added there. One thing I did find in you trying to use ACT is when trying to use ACT, ACT is very verbally mediated. And I found that at times the metaphors of ACT were not playing so well with my teen clients. And again, some of my teen clients are really able to follow that. Not all of them were. So I felt like some of the ACT intervention might have been lost on some of the kids that we were seeing, and we need to do a much bigger study to be definitive. But at the very least, we didn't ruin CBIT, but it didn't seem like ACT added much to CBIT. There's a big study right now. Doug Woods is lead author on what's coming, and they did acceptance enhanced behavior therapy for trichotillomania, and they're comparing it to almost exactly the same protocol. That's an adult trial. They're comparing to supportive counseling and seeing how they do there. So there'll be more evidence, and that's a pretty big study, 90 people, I think. And so they're going to be looking at whether acceptance enhancement added something to CBIT or HRT in the case of trichotillomania. Okay. So a little bit about moderators and predictors of response. This is a very important place to be because we don't have perfect treatment. So we want to know who does respond to them and who doesn't. And what they did on this particular one, published in 2017, is they took both the adult and the kid trial data and collapsed it. So they had 200, pretty large sample, 240 plus. And they were looking to see whether they could find moderators, which is basically prediction of a response to a specific treatment, as opposed to predictors, which is response to treatment regardless of which one it was. And Steve Holland, a friend and colleague of mine, is a depression researcher at Vanderbilt, once said this at a conference, which I really liked, which is every moderator that you find is a proxy for a mediator you haven't discovered yet. So if there's a differential response to a treatment, you got to start asking the question, well, why? Why did it work better for these patients than for those patients? And then you start to get into the weeds as far as, you know, it could well be that there are certain kinds of, an example would be if kids with comorbid ADHD aren't responding as well to CBIT, and they seem to be responding just fine either or comparably to supportive counseling, maybe it's because it's harder for kids with ADHD to learn what needed to be learned in CBIT. So that would be one place where a moderator starts pointing you in a direction of non-adherence or not getting homework done. Maybe that's why it's not as effective for those kids. So that's kind of conceptually where we are, and I can show you the data, what they found. So interesting that they let kids in on med. So they weren't agnostic to that. They didn't exclude people. Which, if you're going to exclude kids into a Tourette's trial who are on medicine, you're going to get a milder sample. So they didn't want to do that. But they had the kids. If you're on med, you stayed on them in a stable dose and duration. And what they did find at that point is that medication status predicted response to supportive counseling. And this is a moderator, so to supportive counseling and not to CBIT. So if you came in already on a med, you tended to do better in supportive counseling than if you weren't on a med, which is interesting. CBIT wasn't affected by that regardless. So CBIT, whether you're on med or not on a med, didn't matter. And then what we also looked at in here, which is ADHD, OCD, and anxiety disorders, which are common comorbidities I mentioned earlier, didn't moderate CBIT response. And the answer to me there, it suggests that CBIT is robust. So whether you have ADHD, whether you have OCD, whether you have an anxiety disorder, whether or not you're on medicine, doesn't influence your outcome. So it's sufficiently robust to say, I don't need to take those things into consideration when I'm making a decision as to whether you're going to be a good candidate for CBIT, which is good. Makes it more flexible. When we look at predictors, so response to treatments, regardless of which ones were received, the greater your tic severity, the better you responded, which is interesting. And the higher your treatment expectancy, the better you responded, regardless of which treatment. Across both, although it wasn't, comorbidity wasn't a moderator for CBIT, but it did seem like the presence of a comorbid anxiety disorder negatively impacted response across both treatments, and greater urge severity was also predictive. So tic severity was predictive of positive outcome. Urge severity, which is really interesting, try to unpack that. Urge severity was a negative predictor. So when we're thinking about these things now, treatment selection. So what does the literature tell us? Literature tells us that meds seem to work in some kids, different meds. We don't have a clear winner. 6 of one, half a dozen of the other, it looks like. So then the psychiatrist is left to make a clinical decision based on side effect profiles, based on kids' response to prior meds, etc. So there's no definitive lead you're going to get from the lit. But we also know that meds might be more readily available than CBIT. CBIT, one of the issues that's being grappled with now is trying to make it more readily available. If you go to the typical child psychologist or even the adult psychologist, There's not great knowledge. Anxiety and depression, I think you could walk into pretty much any office and people are going to feel comfortable treating that. I would say right now we're in a position where people don't feel comfortable treating Tourette's unless they've had specialized training. So there's an availability of expertise issue that needs to be grappled with. Developmental level is also another thing that's got to be taken into account. If I've got a 5-year-old with tics, with eye blinking tics that don't bother the 5-year-old but torment the parents, I don't know if I want to drag that kid through CBIT, because CBIT's going to be a lot of work. CBIT's going to require a lot of their attentional resources and maybe their awareness of the process. And maybe, given what I already know, which is the majority of these kids are going to age out, unless this is really a bad tic that's really affecting their functioning, maybe I want to leave it be until they're in a better position to work on it. But if I have a 7-year-old, alternatively, who is tormented by the fact that they're doing these tics in school and they want to stop, or it's affecting baseball, maybe that is a kid I want to take on. So the developmental level is not just age, it's also intellectual capacity and awareness and motivation, all those complexities. Case complexity is also going to affect treatment selection. So if a kid has tics, but they also have 4 other conditions, and those 4 other conditions are more likely to be associated with functional impairment, I'm probably not going to go after the tics. I'm not going to rearrange the deck chairs in the Titanic if I've got a clinically significant depression in a teenager. I may circle back to them, and also may be that by treating that primary disorder, I can look at what happens with tics, because if I think that there's a stress relationship here, I might see some reduction of tic behavior as I reduce the stress, and maybe it's not as relevant to come back. But if a kid's bothered by the tics, but they're also depressed, I may go after the depression first and revisit at the end when the depression's under better control, revisit their interest in working on the tics. And obviously patient and family preference. I always tell this to families, which is, I quote Bonnie Raitt, which is, I can't make you love me. I also can't make you work on your tics. Like, that is not what we're doing. That is not what most people do. We can't make people do stuff. I can try to motivate them. I can try to get them interested, but if they're not ready to work, this is Prochaska and D. Clementi. I came out of the University of Rhode Island, which is where all of that work came from. And I remember literally my first graduate class, I was putting my hand up as a greatly informed new PhD student, and asked Jim Prochaska, well, if we have all these action-oriented treatments for these various conditions, why don't we simply provide them to the people who have these disorders and get them better? And he gave me a long pause. He called me son at that point. He said, son, there's a lot still to be learned here. And he gave me some smoking cessation data, which was really interesting, which is this is Rhode Island Hospital in the like early 90s. And so Rhode Island Hospital had a smoking cessation program where if you had medically, if your medical problems were influenced by your smoking, they would send you to these programs. And they were finding the programs are not terribly effective. So a lot of people were not stopping their smoking. And so Prochaska and his group came in and started typing people based on readiness for behavior change. And then what emerged from that was a pretty clear story. If you were a contemplator, so you're thinking about changing or you're ready to stop smoking, the interventions were working just fine. So the smoking cessation was highly successful. If you were a pre-contemplator, so you were being told by your doctor you need to stop smoking, and you're saying it's not that big a deal, my grandfather smoked into his 90s, I don't need this, leave me alone, and I sent you to the action-oriented treatment, you were highly likely to drop out. And if you didn't drop out, you were also highly likely not to respond. In fact, they seem to have increases in their smoking over a 6-month period rather than decreases. An I'll show you effect. So the moral of the story is I've got to get people who are ready to do the work in order to do the work. And if the parents are ready and the kid isn't, guess what? You've got the same problem. So just because a family is saying, I'm desperate for you to work on his tics, and the kid's saying it doesn't bother me, it's not that big a deal, and you have evidence from the kid that it's not that big a deal, I don't know if I want to drag you through CBIT at that time. because it may well be that you're going to conclude that CBIT is something that people force upon you. It's not something of your own choosing, and then you're going to wind up having compromised between session adherence, which is a great predictor of outcomes in CBT for OCD. And I would certainly not be shocked to find that was also the truth in Tourette Syndrome. They're probably working their way through the CBIT data to look at exactly that right now. So moral of the story is I need a willing participant. If I don't have a willing participant, maybe I don't want to drag out my CBIT. I can't drag you through it. I'm gonna be cautious about forcing an intervention on somebody who's not ready. And I think this leads us, it's 2:16 here in the East. I have no idea where everybody is, but that leaves us in a position to answer questions. And I think Michelle's gonna vet those questions, and I'm gonna do my best to provide you with coherent answers.
Thank you, Dr. Franklin. Perfect timing. Now it's time to answer questions. And just a reminder, if you do have a question, please use the Q&A button, not the chat feature on the Zoom taskbar. We will try to answer as many questions as we can in the time that we have left. If we don't get to your question, please send me an email message afterwards and I'll follow up with you. There are a couple of questions, Dr. Franklin, on what would be a behavior incompatible with blinking and eye rolling.
Yeah, really good question. And I would say that the most common competing response for the hard blink or this blink, the hamster blink, the most common one is going to be a slow blink. So I don't know if you can see me doing it. So I'm going to engage in my competing response, which is closing them slowly and opening them back up. And doing that over the course of a minute. And you can fuss around with how long you want people to blink, how long you want those eyes closed. All of that's going to be individualized. But usually it's going to be that. If it's an eye darting tic, then I may want to have you focus on a fixed point on the wall or in front of you to hold my eyes steady, which I'm doing right now. I'm looking at the Q&A thing. Instead of doing my darting, I have my urge to do my darting. I'm going to look at Q&A for about a minute. And while I'm doing that, I'll probably blink too. And again, this is the magic of Doug's work, which is that's where I'm going to start. But if a kid tells me that makes my urges stronger or it's not working, I should feel free to try some other some physically compatible competing response. Maybe I try the feet on the floor again. I had a hockey player once who was having trouble on the ice, and his was a neck tic. It was a turn, like almost like he had to turn his head all the way around, like The Exorcist. He's doing this, and if you're playing defense in ice hockey, you cannot be doing that. You lose the puck. And so what we had him fuss with, because he had a bunch of competing responses that weren't going to translate to the ice. I actually had him tensing the top hand of a stick, because if you play ice hockey and you tense the bottom hand, you have no puck control. But I had him tensing the top hand of the stick. Most shifts are about 1 minute to 2 minutes, so he's on there doing 1 minute to 2 minutes of tensing his top hand while he's doing everything else, and it worked like a charm. So it wasn't physically incompatible. It allows me some flexibility, but with an eye tic, I'm going to start in those places.
Thank you. We had a question on, can you elaborate on why you should not praise tic reduction and only praise completion of a competing response?
Yeah, I think that's a really nuanced question. It's a good one. And the reason I want to praise response as opposed to tic reduction is because to an extent, these things are going to occur when they're going to occur. And I don't want to spend a lot of time telling kids, I'm so proud of you for not doing your tics, when that has maybe not so much to do with you. What do you control? And that's, to me, that's always where I want to wind up. What does a kid control? Do they control whether or not the tic urges are so strong that they're coming with great frequency, or do they control how they respond in the presence of those urges, regardless of their strength? I think they control the latter. So I want to reinforce their controlling what they control and not get them stuck on, because sometimes you just have a bad day. And if you have a bad day and you have really strong urges and really frequent urges, I don't want to now be in the position where I was praising you for not doing your tics, and now you're having a bad day, and the silence of my praise is going to be noticeable. Cal Ripken wrote a book about parenting athletes, which I loved, and famous Baltimore Orioles shortstop. And what he said in his Little League, his version of Little League, they have days where parents aren't allowed to cheer. So you come to the game, and you're not allowed to cheer. And the reason he said that they implemented that was because, you can probably get parents to not scream at their kids when they strike out. But what you can't do is if a kid gets a base hit and the parents are going crazy and throwing ticker tape, then when the kid strikes out, the contrast, the crickets as they walk back into the dugout, the contrast sort of reminds the kid that you failed. And in a sport like baseball, where failure is the norm, his point was, I want kids to learn the game and be focused on it internally, not have all these other things going on. So I think it kind of fits that view, which is, if I'm praising you for not doing your tics, what am I telling you when I'm not praising you when you are doing tics? And I think I'd rather focus on you controlling what you control. Control the controllables. That's the old saying.
Thank you. Your next question is, can a mental health provider deliver CBIT treatment by following a manual without having previous experience with the treatment?
That's a fabulous question. And I think the answer is we don't know yet. Doug Woods and Michael Himley are doing a lot of work. Doug is, as I said, at Marquette. Michael Himley is in the vanguard here, University of Utah, looking at different ways to get this treatment out there and to get it to providers and to get it directly to patients as well. And I think there's some work to be done yet. One thing we do know from anxiety disorders, this is really interesting, is if you go to a workshop and you're not an expert in anxiety disorder, you go to a workshop and we give you a couple of days of focused training. And this was well done study, Renad Batis, my colleague at Penn, where they randomized treatment providers to come to the workshop only versus coming to the workshop and then getting ongoing consultation. And what was interesting about that study was, if you came to the workshop only, we certainly can change your knowledge of anxiety disorders. But when we came back and looked at what you were doing in session, 6 months later, a year out, it wasn't much different than what you were doing beforehand. If I gave you the workshop plus the ongoing consultations, not only could we change your knowledge, but we could also change your behavior in terms of you're now using the techniques. So if I'm and I don't think it's too far to extrapolate across these empirical gaps. If that's true of anxiety disorder, it's probably true of Tourette's as well. So my sense is, if you can get training, and I know the Tourette Association of America does a ton of training. And so there are training opportunities out there. And I would think that you'd feel more confident and more comfortable if you got the training and the ongoing consultations, which I think they use the same model that the International OCD Foundation uses. And I do a ton of those trainings. So we come, we give a workshop, then we have ongoing consultation with folks. That model, if you can avail yourself of that model, you're going to be in a better position. On the other hand, if you're in northern Idaho, where there's not a living soul who knows anything about CBIT, and you're the local psychologist, and a Tourette's case comes, I would think that with some supportive materials, again, is it optimal? No. But at the same time, if your alternative is say, well, I can't do it optimally, therefore I can't do it, I'm not sure I like the ethics of that. And again, I may have online opportunities now that I didn't have 10 years ago. But if someone came to me and I didn't know the disorder well, but I knew how to get the materials and I could get some consultation, I'd feel more comfortable taking that case than not.
Thank you. The next question is, what is your recommendation for an adolescent who, with prominent motor and vocal tics, who insists that they are not bothered by the tics, but has parents who are determined that the tics need treatment?
Yeah, I think I alluded to that earlier, which is, I've got to have the motivation's got to come from the person who has to do the work. And if they're not interested in doing the work, then I can imagine the work won't go well. So I'm going to spend a little bit of time in that context. I'm not going to say, well, you're not motivated, therefore get out of my office. That's not usually the way that we are choosing to operate. So I will spend some time trying to do what we call motivational interviewing. So I'll try to see if there's some way I can improve your awareness, if there's some way, and sometimes kids are going to tell you it doesn't bother them because the parents are talking about it every night at dinner. And if you want to get a kid to be defensive, that's a good way to do it. So I want to see if that's what's going on, and maybe the kid does acknowledge and recognize problems, but they don't want to admit it, which is a different issue than if they really don't see it or it really truly doesn't bother me. Like I blink a lot. Who cares? And for the kid, especially a younger kid, maybe that is the case, and maybe they can circle back to it. I think I want to make them aware of the possibility of a treatment. I want to explain what that treatment is, and then I'm going to be agnostic to their answer. And in the end, I'm going to respect the kid, because if I'm going to drag you through CBIT, and then you're not going to follow through, and you're not going to adhere both in session and especially between, I'm going to get an attenuated outcome. And you're going to conclude that CBIT doesn't work. I'd rather you not do that. Come back when you're ready. But I'm going to try to get you a little bit ready, but I'm not going to spend a ton of time on it. In a subspecialty practice where what I'm supposed to be doing is treating these conditions. If you're a generalist psychologist, you may spend some time trying to get kids ready in the ways I'm describing, but a lot of the subspecialty shops, you're either treating it or you're not.
Thank you. So for our final question, does the competing response ever become another tic?
I think it depends on how you conceptualize it. And so to me, if I'm using a competing response in an intentional manner, and I'm using it in order to prevent myself from reinforcing the urge to do the tic I'm trying to get rid of, it's a repetitive behavior, sure, but I don't know if it functions the same way a tic does. Now, tics move. And so if I start doing this behavior that used to be a competing response and now suddenly like pushing my arms is a good one. So now I have to push my arms. I have an urge to push my arms. Then it's a little bit like whack-a-mole. I may give that kid a competing response of relaxing their arms. But in the end, if I'm substituting, because your substitution here is important, I don't ever give a kid a competing response that's standing up in the middle of the classroom and doing jumping jacks. So my competing response has to be less noticeable and easier on the kid than the thing I'm trying to get rid of. And if I'm good about that, and over time we see that the need for the competing response dissipates in response to urge reduction, eventually it ought to fade. But if it starts to take on an involuntary flavor, or I having these urges as opposed to I want to do this to make myself give myself a chance to control these tics better, then I don't worry about it too much.
Thank you so much. And that's all the time that we have for questions. If I didn't get to your question, please feel free to send an email to webinars@rogersbh.org. Dr. Franklin, thank you for taking time away from your clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask Dr. Franklin to share a few additional resources on this topic with our participants.
So formerly the Tourette Syndrome Association of America, now Tourette Association of America. A lot of fabulous information, and definitely the place you want to look if you're interested enough in CBIT to be seeking additional training. That's where I'd be.
Well, thank you. And that about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you'll receive an email with a link with your personal dashboard on ce-go.com, where you'll be able to access PDFs of the PowerPoint presentation slides, handout, and the complete list of references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up, please contact support at ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to support your patients. Thank you.
Thank you.